Yeah, so I'm Laura Ormesher. I'm an academic clinical lecturer based at the University of Manchester and St Mary's Hospital. So I am a doctor who works clinically in obstetrics and gynecology and then does research all around hypertension and cardiovascular health. And my role within Poppy is I am the principal investigator, so PI for the Manchester site.
And my name's Ruth Morello. I'm the research midwife working at St Mary's Hospital on the Poppy study.
So yeah, the Poppy study is all about trying to understand the relationship between pregnancy complications and future health. So by pregnancy complications, we are talking about placental syndrome. So the placenta is the afterbirth. It's what feeds the baby during the pregnancy. Placental complications or syndromes include things like preeclampsia, gestational hypertension, so high blood pressure in pregnancy, or fetal growth restriction, so where the baby's growth is affected. And there is lots of evidence from big population studies that say that women who have these placental syndromes are at increased risk of future health problems like heart disease and diabetes. But what we don't really understand is the why. What we want to know is the sort of chicken and the egg question, what comes first? So are women who develop these complications, pregnancy is often described as a stress test to the heart. So have they essentially failed their stress test and revealed themselves as they were always at risk of these future health problems, and they revealed themselves during pregnancy at risk by developing these pregnancy complications? Or is it the other way around? Do these pregnancy complications actually cause some kind of insult to mum's cardiovascular, so heart, vessel, metabolic health, such that those pregnancy complications cause them to be at increased risk of future health problems? So preeclampsia is a condition that's caused by the placenta, so as I said, the afterbirth. It's very much thought of as a pregnancy condition. So for some reason or another, the placenta becomes stressed. It releases things into mum's circulation, into mum's bloodstream, such that it causes mum's blood vessels to constrict. So that gives them high blood pressure, and it causes them to be leaky, and it can affect some of mum's organs, like their liver, their kidneys, for instance, and it can affect the feeding of baby via the placenta. So baby can be on the smaller side. It's always been thought of as a pregnancy condition. So when the placenta is out, i.e. after baby is born, it goes away. But what we know is that's not quite true. Although it's caused by the placenta, there are lasting, lifelong implications. And that's what we were saying before. Women who have preeclampsia are then at a much higher risk of developing health problems in the future. Not only do they occur more commonly in these women, but they occur earlier in these women. So we know that even though the cure for preeclampsia is for baby to be born and the placenta to be delivered, there are lasting impacts on a woman's health. So women who have had preeclampsia are then at increased risk of high blood pressure, heart attacks, strokes, heart-related death, diabetes, all of those things in the future.
We're looking for women who haven't had a baby yet, and that really relates to what Laura was talking about earlier, about pregnancy being a bit of a stress test. We know that preeclampsia can have a long-term impact on a person's heart health. We don't know whether that person might have been predisposed to it before. So actually meeting people before they become pregnant, doing a really thorough assessment of their heart health before they become pregnant gives us something very useful to refer back to when we've followed them through pregnancy and seen how their pregnancy has developed. So we can then compare people who do go on to develop preeclampsia or other placental syndromes with people who have a healthy pregnancy, but look back at any predisposing factors that we might have picked up in the pre-pregnancy assessments. We see all the participants for a baseline visit, which is pre-pregnancy, and that's a very thorough assessment of their heart health. We ask lots of questions as well about things like diet and exercise, family history, their own personal medical history. So we gather lots of information, we do lots of blood pressures, we take some blood tests, Laura does an echo of their heart. So there's a really thorough assessment of their heart health at that point. And then for the people who do become pregnant, we see them several times during the pregnancy, and again make those same assessments. And then for most people, not everybody actually, but for most people, we'll see them postnatally as well and do the same assessments again. So they get these same tests at several time points. And then you also asked about support. So we are able to reimburse participants for their time and travel costs.
I think if we have a better understanding of that relationship between pregnancy complications and future health, and whether this precedes the pregnancy, if those women who develop those pregnancy complications were inherently different at the start before that pregnancy, it can help us support women appropriately, basically. So if we demonstrate that they actually have more risk factors for poor cardiometabolic health before pregnancy, we will be able to offer support and advice and education for women to improve their health before pregnancy, to reduce their risk of preeclampsia and other pregnancy complications. On the flip side, if we demonstrate actually these women are comparable, there's no difference between them before the pregnancy, but the women who get the complications in pregnancy are then different after pregnancy, that suggests that something that's happening there is causing an insult to their health. And then that really adds evidence to say we need to be supporting these women better after childbirth if they've had a complicated pregnancy, trying to support how we treat these risk factors, how we treat their blood pressure, how we manage their other risk factors that put them at a higher risk of future health problems, ultimately aiming together to reduce their risk of pregnancy complications in the future and to reduce their risk of long-term health problems. The results will always be shared in an anonymous way. So there is no way that anyone will be able to link back and work out who that information came from. So you won't be able to identify the research participants, but the findings from the study will be shared via a number of means. So they'll be shared at conferences and published in scientific journals. So that will largely be with scientists, researchers, medical healthcare professionals. But then the findings absolutely need to reach the wider public. So there are a number of established communication sort of links. So we'll be going through charities, for instance, APEC, which is Action and Preeclampsia Charity, and Association of South Asian Midwives is another charity that the research is involved with. The study is led by Cambridge University, so they have a number of communication links as well. And all of the NHS trusts, for instance, St Mary's Hospital, Manchester University NHS Trust, and a number of the other NHS trusts contributing to this research will have means of spreading the word. I think we've also used social media quite a lot to recruit women, and we will use social media to disseminate, to publicise our findings as well. So hopefully there should be a number of means by which women and others can access this information once we are ready to share.
All research that involves human participants has to follow certain guidelines that protect the rights and the safety of those participants. So people taking part in research, their health comes before the objectives of the research at all times. So that's one really important thing that I hope would reassure people about the safety of taking part. But the other thing to say is that this research is purely observational. So we're not testing a new way of working, we're not testing a new medication, we are just doing health assessments of the women who choose to take part before pregnancy, during pregnancy and afterwards. So the risk of any harm happening to them is very, very minimal. And then I would just add, really, there's benefits because actually, as Laura was saying before, we're going to do a health assessment for them that they probably wouldn't have had. So in fact, there's opportunities to pick up problems if they are there and start managing those and treating things before a woman becomes pregnant. It's much more complicated to try and fix a health problem in pregnancy. It's much better to get somebody really nice and healthy before they become pregnant. So that's an opportunity that comes with taking part in the Poppy study. So anybody wanting to take part in the research can fill out an online expression of interest form, which they can either access through a QR code, or they can go to www.poppyuk.net. Good quality research, the sample of people taking part in the research needs to represent the population as a whole. So we're very, very keen to see women in this study who are from all different backgrounds, so that we can be sure that our findings actually can represent the population as a whole.